Hello, it's Kate Wakelin here from Neuroendocrine Cancer Australia, and it's Friday the 6th of November. So here we are having a Facebook Friday chat once again. So welcome to everyone who is joining us live from our Facebook group and those who are watching the video later on. You will see that I am joined on the screen with a person who will be a familiar face to many people, Dr. Grace Kong from Peter MacCallum Cancer Institute or Cancer Centre in Melbourne. Grace Kong is a nuclear medicine physician, and she's really generously agreed to spend some time with us today unpacking some of those tricky and sticky questions around nuclear medicine and peptides and somatostatin receptors and imaging and therapy. So I am thrilled to have you along, Grace.
Thank you very much for having me.
Just before we continue, I just would like to pay acknowledgement to the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation, and would just like to pay my respects to elders past, present and emerging. One of the things I love about where I live is that I live very close to the Yarra River, which in the Woiwurrung language is called the Birrarung. And I love to go running along that river, and I feel very grateful for where I am. So I know that people are joining me from all corners of Australia and even beyond. And so welcome to everybody who's watching us. I can see there's a few people who've already joined us. So Grace, I often do give a bit of an update about COVID-19 as part of these talks as well. Those of you in Australia and maybe even more specifically in Victoria will know that we're celebrating quite enthusiastically now because we're having very low levels, actually no new diagnoses over the last 6 or 7 days, which is really exciting. So we're keeping our fingers crossed that that might mean that we've really managed to certainly break the back of the impact of this virus in Victoria. And I know other states are doing very well as well. And we think of our community, our broader community internationally and in Europe and in the United Kingdom and USA and broadly through Asia, with the impact of this virus on you, not only as people, but people who are living with a serious illness, and knowing that this is having a big impact on availability of treatments and care. So we think of you and, you know, just send our support from Australia. So Grace, thank you so much once again for joining us. It's really fantastic to have you along. I know that you are extremely busy with your clinics and meetings and things at Peter MacCallum, but yeah, we're so grateful to you for joining us. We've had some fantastic questions put in by our audience, and there may well be some questions that people share from the live feed as well. So I'll keep an eye on what people are writing, and hopefully we'll be able to sort of feed those questions in as we go. But I just wondered if it might be a good place to start for you to explain somatostatin receptors, and because I think that's really sort of like the premise. It's a really basic piece of information that it's good to understand when we're talking about the nuclear medicine imaging and treatments. Would that be a good place to start for you?
Yeah, absolutely. I think thank you for the question, and thank you very much for having me here today as well. Somatostatin receptors is really the fundamental part of nuclear medicine, as you say. Actually, am I able to take this opportunity perhaps to show some pictures?
I think that we'll give that a go. And for those of you who are long friends of Facebook Friday will know that we've had some technical troubles early in the day, but we're going to give it a try, and maybe people can, hopefully they can see the screen.
Yeah. So can you see the screen here, Kate?
I can see what you're, I can see you sharing your screen.
Great. So, I mean, I'll explain it as I go along as well, obviously. So one of the very special characteristics for neuroendocrine tumors, what we call them NETs, is that majority or a very high proportion of them have a very special characteristic or a receptor that sits on the cell surface. And it's a bit like a lock. So on the screen here, if you can see it, let's imagine that that is the neuroendocrine tumor cell, and the green structure is like a lock that sticks out of it. And it is a characteristic of NET cells, actually. It's not present in majority of other tumors, for example, breast cancer, prostate cancer, colon cancer. They don't actually have this lock. So it is actually something very special to neuroendocrine tumors. So you can imagine on the top of the screen here, you have normal cells, and this is a tumor lump that is formed by many small neuroendocrine tumor cells. So if there is a lock on the tumor, you can kind of picture that the lock can actually sit on the cell surface like that. One of the special characteristic about this is that for the lock, we have a special key that we can bind onto it. And the key is what we call octreotide or octreotide. So it is a little protein. And chemists or scientists are very smart. We can actually now link this particular protein octreotide to a form of radiation. So I know there are a lot of questions about GATATE scanning, PET scanning, FDG scanning. But let's just take the GATATE PET scanning into this context. So what GATATE PET scanning is about is we basically can label a small amount of radiation called gallium onto this key, which is octreotide. So the full name of this compound is called gallium octreotide, and in short form, we call it a GATATE.
So Grace, can I just interrupt you? Because I know that in our group, we have people who talk about GATATE scans, dotatate scans. Sometimes they shorten them to dotate scans. We have gallium-68 scans. This is all the same scan, am I right?
Exactly right. I know the terminology can be very confusing. It can be very confusing even for doctors, to be honest. But the basic concept is the linking of radiation, which is gallium-68, to a little protein. And this protein, there are several forms. The most commonly used form is octreotide, but we also have octreotide as well. So if we, the full name of this will be gallium octreotide in a short form called GATATE scan. So I think that's the most common terminology that we use to describe these radio traces. So when you come into the department, to the PET center, if you've already had a PET scan, you would know that the technologist will basically put a little needle into your vein, and they will inject a very small amount of radiation or medicine into your body. So that medicine that they inject for the GATATE PET scan is essentially gallium octreotide. So once injected, you will lie down, wait for about 40 minutes or so. And the gallium octreotide, or let's keep it simple, we call it GATATE, will circulate around your body. Look, if your net cells have these lock on the cell surface, basically the radiation will go around and the key will stick onto the lock, bringing along the radiation with it. So when we then put a camera over your body, the net cells with the lock will have radiation on it. Basically, it will light up the net cells under the camera. But if your tumors do not have these lock, basically the key will not stick onto anywhere. It will not light up your neuroendocrine tumors. So that is the basis of why the lock is so important in detection of neuroendocrine tumors, because we want to find them. That brings me to the next slide here. Perhaps I thought it would be nice to show some pictures so that you can actually visualize what I'm talking about. So this is what we see as a GATATE PET-CT scan. So this is, imagine you looking at a mirror into yourself. Can you see my mouse moving, Kate?
Yes, yes,
okay.
We can.
So we have your head with your arms up like that, and your upper body, your chest, your tummy area, and then your legs will be down here. Now, because it is an injection, the injection will go around the body before it comes out. So it will also highlight some of the normal parts of the body as well. So let me now just point out to you some normal parts of the body, which we call physiologic uptake. So that little spot up in your head here is your pituitary gland, which is normal because the pituitary gland is full of neuroendocrine type cells. Very light gray here is the salivary gland. You can see a structure here, which is your spleen. The two jelly bean looking structure on the left side and the right side, they are your kidneys, because the medicine basically goes around and it comes out through your waterworks or your urine. So that's your bladder. So areas that look black on this particular image is areas where radiation has gone to. So that's your normal bladder, because after the injection, when you go to the toilet, basically you'll be producing a small amount of radioactive urine. But what is not normal here is all these black areas on the top or the upper part of your abdomen. They are black because it's picked up the radiation. And essentially for this particular example, these areas are the liver tumors in the liver. And the fact that it's black is because it has a lot of lock or receptors on it, and the gallium octreotide has gone into those areas. That smaller part is the small bowel primary tumor. So you can see even small areas can actually light up very black or very brightly on the gallium dotatate PET-CT. So it's a great way of highlighting where the tumors are, if the tumors have the lock on the cell surface. And the high proportion of neuroendocrine tumors, particularly for the well-differentiated type, will have the lock on the surface. Now, Kate, I also have a picture to demonstrate or explain what is an FDG PET scan. Do you think that would be appropriate?
I think that's perfect timing, because
Okay.
I'm sure people are wondering, well, that's how the Gattate scan works. Why
Yes.
are people talking about FDG
Exactly.
scans?
So just to wind the clock back a little bit, there are obviously many different types of scans that can be performed these days in the radiology department: CT scans, MRIs, ultrasounds, etc. And basically different scans look for different things. The most commonly used scan is a CT scan, and the CT scan is very good at looking at very detailed anatomy, where we can put measurements and calipers on things to measure exactly how big things are. But in terms of nuclear medicine, there are two particular scans that we use very commonly for patients with NET. One is obviously the Gattate PET-CT that I've described before, which looks specifically at the neuroendocrine tumor cells. Some of you may hear about an FDG PET scan. Now, an FDG PET scan actually looks at a completely different thing. So FDG really stands for fluorodeoxyglucose. So basically, the main word that you can remember from this is glucose. It is a sugar scan. So the injection that is given to you is not gallium labeled with octreotide, but a small amount of radioactivity labeled with sugar. So once the medicine goes into your body, it will go to areas that utilizes sugar for metabolism. So an FDG PET scan is actually not specifically looking at cancer cells per se, because if you have a big infection in your lungs, for example, infection uses glucose for energy. So infections, pneumonia can light up very brightly on the FDG PET scan as well. I can tell immediately that this is an FDG PET scan because you can see from the head that there's an area of black, which is your brain. And your brain naturally, of course, uses glucose for energy. So this is a normal brain that we're looking at. But in the context of neuroendocrine tumors, it is actually very helpful because, as you know, broadly speaking, there's a group of neuroendocrine tumors, grade 1, more slowly growing. And on the other hand, we have tumors that are a lot more active, and they tend to grow quicker. So with FDG PET scan, the main use of it is to characterize how active your tumors are. Because for patients with a very slowly growing indolent tumor, grade 1, they tend to grow very slowly. So they do not tend to use up glucose or sugar much at all. Like this case, you can see that for this is exactly the same person where the liver tumors highlighted in black with lots of lock on it, but hardly any of them are lighting up black on the FDG scan. So this tells us that it is a relatively slow growing type of tumor. On the other hand, if things are growing much quicker, they will tend to use glucose as well, or sugar. So then they would actually light up on this FDG scan. So I will show you another example, which is this one.
Sorry, Grace, before you
Yes.
go on, I noticed just in the previous picture, you can't see that big black circle that you can see on the middle of the FDG scan. You can't see that on the Gattate scan. So would it be true to say that some of those locks, some of those somatostatin receptors tend to disappear on the tumors that are growing more quickly, on the higher grade tumors?
Yes, absolutely. So Kate, apologies, I should have pointed out the physiologic uptake of FDG as well. So with an FDG PET scan, what we expect to see is, which is normal, is the brain. It uses sugar. This is in fact the heart. So the heart variably takes up sugar. So that's actually a normal structure. And also the FDG comes out from your body through your bladder. So that is the black part down below underneath is your bladder activity. And that's the outline of the liver and outline of the spleen, as well as outline of your kidneys. So these are fairly normal looking structures here. So I will show you another example here where on the Gattate PET scan on this side in green, similarly, this patient has a very, very big tumor in the upper abdomen with somatostatin receptor. So we know it is a NET, and we know it takes up radiation. And the FDG PET scan in this person shows a similar area, also, very black, meaning that it is taking up sugar, meaning it's a more active tumor here. And it does guide management, because if we know something is more active, then we should sort of act on it earlier rather than later. And the third example, and the last example that I'll show you here, Kate, is refers to exactly the scenario that you were talking about before. So in this particular scenario, this patient clearly has somatostatin receptor positive NET on the liver, but the red arrow is pointing to an area that looks very, very different, isn't it? On the sugar FDG PET scan is very black, meaning majority of this lesion is using up a lot of energy, but is only showing very patchy uptake on the GATTATE PET. So for this particular case, for higher grade tumors, they may actually lose the LOX on the cell surface, but yet we know it's there and it's very active because it is using a lot of sugar. So basically these two scans are quite different, but it provides very complementary information to guide clinicians as well as the patients what sort of treatment is suitable. And so obviously the next question probably would be, okay, well, PRRT, we know that one of the main criteria for selecting people for PRRT is by doing one of these GATTATE PET-CT, because we need to know that the tumors actually take up or have the lock for us to then deliver the radiation to those places. So the difference between GATTATE imaging and PRRT is simply that we replace the gallium, which is a small dose of radiation, to a very powerful radiation called lutetium. And because we label it to the similar peptide or octreotide, we know that if the tumors contain a lot of these LOX on the low dose scan, we expect the high dose lutetium octreotide treatment to be going to exactly the same area, but this time delivering a very high amount of radiation to target those cells to cause some damages. So for PRRT to work, we basically have to ensure that all the sites contain the lock. In this situation, if there are sites that are more active that doesn't have the lock, then another option will have to be considered for patients. So maybe I'll just unshare my screen at the moment, unless you have any particular questions about these scans, Kate?
I did actually, Grace. Just looking through the questions that were put in by our Facebook group leading up to, these scans, obviously you're zoning right in on that person's tummy, but am I right in saying that you can see on it, when you're actually looking at the PET scan, you can see the person's whole body, so you can see their hands and their feet?
Yeah, so the typical range that we scan the patients is kind of what you see here. We typically would scan them from the head, from the top of the head to around the upper thigh. So this is the typical range of area that we do the scan for. But if we do have any suspicion of any particular areas of concern that is in the hands or the feet, then certainly we can incorporate those areas into the field that we scan the patients as well.
So the other question I had, Grace, was clearly we do these scans as well as doing ultrasounds and CT scans and other imaging. So, sorry, I've just dropped my pen. So I'm imagining then that there is different information that you get from these scans that then you would get from an MRI or from a CT scan.
Yeah, that's correct. So different types of scans provide different sort of images. Unfortunately, we're not quite there in technology in terms of doing one magical scan that detects everything. So typically the CT scan goes from, wherever you want it to scan, chest, abdomen, and it provides very, very good detail of where the organ sits. You're actually looking at the heart, looking at the liver. MRI is a little bit different, but it also provides very good detail, particularly with the liver structures and the blood vessels. But nuclear medicine, as you can see, we are actually trying to we're not just trying to pick up a lump, because we know where the lumps are from the CT, but we're trying to use nuclear medicine to target specific parts of the tumor to highlight its function. For example, the GATTATE PET, we're trying to look at the LOX, the somatostatin receptors on the net. The glucose PET scan, we're trying to pick up the activity, which that information cannot really be seen on a single CT scan, for example. And often it's all complementary information.
And I wondered, Grace, because I have heard situations where a person has had a CT scan and it hasn't shown any abnormality, but then they've had the gallium-68 PET scan and there have been lesions identified. So can you explain how that occurs?
Yeah, that's a very good question. As you can imagine on the CT scan, because it basically scans from, whatever region that you want to do, chest or abdomen, in very, very fine slices and fine detail. So you actually see a lot of information on the CT. And sometimes when lesions are small, it can be very easily missed on the CT scan. When radiologists look at the CT images, typically very small lesions, you cannot 100% say that they are abnormal, because tiny lymph nodes, maybe just because of a cough and cold, and you may have the lymph node that pops up. So the usual criteria, for example, for a lymph node to be called abnormal on a CT is by size. So anything, for example, bigger than 1 centimeter, then they would be worried about it. Anything less than 1 centimeter, they might mention it, but they might not be sure whether it's cancer related or just inflammatory. So CT scans, although it's very, very detailed, there are some potential downfalls for that. However, with the gallium octreotide scan, which is a scan that we look specifically for neuroendocrine tumor cells, as you can see, very small lesions, even millimeters in size, where radiologists would not call abnormal on the CT, if they have the locks on the cell surface, it will light up very, very brightly on the GAT8 PET. So again, complementary information that different scans are providing us, but sometimes with small lesions that are difficult to characterize on CT, if they light up very brightly on the GAT8 images, then that gives us the answer. And the other point also to make is that sometimes CT scans are very difficult to look at the bony lesions, so abnormalities within the bone, because they're very difficult to measure. So that's one thing that CT scans are not very good for, is to identify bony disease. But on the GAT8 PET, again, if the lesions contain the lock on the cell surface, it will light up very brightly on the PET.
And just one more question before we move on, Grace. And everyone will know that I save these questions up from lots of phone calls from patients, as well as the questions that were submitted by the Facebook group members. So I'm actually really thrilled to be able to put you on the spot and grill you. The question was, oh, this is different from a bone scan, and why would we do a bone scan in as opposed to doing a gallium-68? Is it that it's more economical, or what's the difference between those two scans?
Yeah, look, that's a good question. Thank you for that. Bone scan is a completely different type of scan. It is done in nuclear medicine, so it's a very commonly done scan for other malignancies. So bone scan involves an injection, again, into the vein, but the injection is called it's labeled with PETCT, with MDP, which is a phosphate, which particularly goes to bone. So it is a scan that highlights the skeleton and just the bony structures. It doesn't tell us anything much about the abdomen or what's in the chest. So it's specifically looking at the skeleton and the abnormalities. Look, it's a commonly done test in nuclear medicine, but I must admit that now that we have a gallium dotatate PET that's more available now, that is actually highlighting neuroendocrine tumors specifically, a gallium dotatate PET would be a more superior test compared to a bone scan, and I guess much more commonly done these days for NET patients at least.
Okay. Oh, thank you, Grace, and apologies because I sprung that question on you without warning you, but it just came to me and I thought, oh, I have to ask it, because one of my patients was actually asking me that on the phone this week. Maybe if we unshare the screen, because I'll just have a look and see. There's lots of people saying hello. So one person has said, please can we go over time today? So that's a cheeky comment, just saying, and I guess just saying that this is so valuable to have you on the spot like this to be able to answer our questions. So
I'll do my best.
I think we're all coming along with you. So that's fantastic to see that everyone's still able to see us. I wondered just, Gallium-68 PET scans, are they the same from state to state and hospital to hospital? Do we want to be having the same scan at the same hospital each time, or does it matter if you have one in Tasmania and one in Melbourne, or one in Melbourne and one at the Royal Brisbane? Like, is there much variation from machine to machine?
Yeah. Well, yeah, that's a good question. I think we're in a very, very good position now in 2020. If you asked me this question maybe 10 years ago, I may have a different answer back then. But I mean, there are two main components to a gallium dotatate PET-CT. One is obviously the GATATE, the injection component, and the other is the PET-CT, which is the camera component. But the injection is pretty much fairly comparable between different places. The main potential difference with this technology is the camera, so the PET-CT camera. There are many different types of models out there, different sort of ranges in terms of it being advanced or not advanced. But I think currently in 2020, most of the departments will have very good quality cameras, to be honest. And we're also fortunate to be in a position where I think GATATE or PET-CTs are actually available in most of the states now. So fairly sort of accessible in most places. So not really too concerned about different major differences in quality, etc. Although we may see some slight differences between cameras. But I think the most crucial actually is when you have a scan done wherever it is to have a previous scan, if you had a previous scan for the people interpreting the images to compare them. Because if it's to do with comparing one time point to another time point, it's very important to then make the effort of trying to get that previous time point, if it was done somewhere else, to the person who's looking at the images to make a good comparison. Yeah, but obviously it will be preferable to have images performed in the same camera. That would be preferable, but at the moment I don't think it's a major problem.
That's really great to have clarified, Grace. One other question that came through the questions that were submitted by people earlier was regarding functioning and non-functioning tumours. And maybe I'll read the question out. It was, if a tumour shows up on a GATATE scan, but you're not sure if your tumour is functioning because your symptoms could be unrelated, will PRRT, this is a complicated question, will PRRT still work? So I guess maybe the question is around, well, what does functioning and non-functioning mean? And what relation does that then have to what we see on the scans and what we can use PRRT to treat? Okay, all right. Okay, thank you. So it is a fairly complex question, but I guess just to make it kind of simple, functioning, non-functioning, it's a very broad term, and I think people may interpret, this term a little bit differently. But I guess from my perspective, or usually from the medical perspective, when we say that a tumor is functioning, it would mean that a tumor is producing chemicals. As you know, another characteristic with NETs is that one, they have a special lock on the cell surface. The other characteristic is that some of these tumors can make hormones. For example, some of the small bowel tumors, if they make hormones, then those hormones can cause flushing and diarrhea. I mean, that's quite a classical type symptoms. Some of the tumors, if they come from the pancreas, can secrete even more special hormones, like they can secrete something like insulin, which makes the blood sugar go low, or glucagon, that makes the blood sugar go high. So there's a variety of different clinical syndromes that we can come across depending on what type of hormones the tumors actually secrete. So I guess for the purpose of answering this question, we'll stick to functional, being tumors producing the hormones causing clinical symptoms. Now back to PRRT. I think there are mainly two main reasons or effectiveness that we would give PRRT for. One is that if we know that the tumors are changing in size or growing, we would like to, and if they have a high level of the LOX on the cell surface, that we know that we can give some treatment with the high dose radiation targeting those areas to control the tumors. So one of the main aim for PRRT is tumor control.
what we call oncologic control. So hopefully to stabilize the disease, and sometimes we can even achieve a shrinkage of the tumor. So that's one reason why we would give PRRT. The other main reason why we would give it is also to control the functional symptoms. So if we know that the particular tumor, if they're not growing, but they're producing a lot of these chemicals, making your quality of life miserable because of the flushing or diarrhea, and it's not controlled with somatostatin analogs, for example, then PRRT can be very effective, because when we give the radiation targeting the cells, one of the first things it does is causes some damage to the tumors to reduce the amount of chemicals that is being produced. So it is actually very effective in terms of controlling flushing and diarrhea.
So I wondered if the question was also, I think that's fantastic, and I hope that's a useful explanation for people, because it certainly made sense to me. I wondered if the question was also alluding to, or the question was wondering whether having functional syndrome might mean that the tumours are more likely to have those locks, those somatostatin receptors, and then maybe be more amenable to PRRT treatment. I might be taking a leap beyond what the person who asked the question was thinking, but could you comment on that?
Yeah. Look, usually people with functioning tumors, so tumors that produce hormones, they usually have very high levels of somatostatin receptors on them, because they are usually the more well-differentiated type that resembles where they come from. So I guess this is a generalization, but most of the time patients with functioning tumors, we would see positive scan, and therefore we can target those lesions with PRRT. And we may not necessarily need to wait for tumors to grow in that situation, because if we know that the symptoms are affecting people, and if they're not being controlled by conventional measures like somatostatin analogs, then we can still consider giving PRRT to control those symptoms.
Fantastic. Grace, let's talk a bit more about PRRT. One of the questions that someone asked, which I thought was pretty astute, and indicated they might have been doing some reading, was that lutate's not the only isotope, is it, that can be used in PRRT? Could you talk a bit about that?
Yeah, sure. Yeah, I'm usually very impressed with patients who come with neuroendocrine tumors, because, as you say, they are usually, they've already done a lot of research, so that's fantastic. There are actually three types of radiation at the moment that we can use. I'll just mention the first one is not very commonly used at all. It's called indium. So indium basically gives off very, very short radiation, and so it's not very powerful. We used to use indium many, many years ago, when the more commonly used lutetium wasn't available back then. So that was used back then, but it's actually not clinically used very much anymore. The most commonly used radiation that is linked with the octreotate is called lutetium. So lutetium-177. So this is the most commonly used type of radiation that we use for PRRT purposes, because the physical property is quite nice. The radiation gives off in a pathway of around 1 to 2 millimeters in length. So if all your neuroendocrine tumor cells have the locks on it, it can actually cause a lot of radiation into the cells within a very, very short distance. So it is effective in terms of giving radiation to the tumor, but also relatively sparing the surrounding normal structures. The third type of radiation that we can use is called yttrium, Y90. So yttrium is actually the most powerful one, because with the radiation pathway, it shoots off about 1 centimeter in length. So it is quite powerful, quite long, and obviously it can provide a very high amount of radiation within the tumors. However, you can imagine that some of the radiation can also overshoot and touch the surrounding structures. So with yttrium, it is actually more powerful, potentially more effective in terms of shrinking tumors, but also carries a potentially higher risk of side effects, because it can touch the surrounding liver, for example. We have to closely monitor the bone marrow and the kidneys. Yeah.
And what sort of reason what would be some of the reasons you would choose yttrium rich
Yeah, so we
rather
would
than...
selectively choose yttrium to treat big bulky tumors. So size is the main selection criteria for yttrium, because small lesions that are tiny, you probably will not really use yttrium, balancing the potential side effects. But bigger tumors, sort of in the order of 4 centimeters or above, we probably will need something stronger. So yttrium will be considered for those people. But even if we use yttrium, we will usually not give it for the whole 4 cycles. We would usually give it for 1 or 2, and then revert back to the standard, which is the lutetium treatment. However, I must say at the moment, in November 2020, yttrium is not currently available at the moment because of COVID and production type problems. But obviously, we're still getting lutetium, so yeah, that hasn't affected our particular service at the moment for lutetium delivery.
So it sounds very much like the treatments are so customized to each individual person, Grace.
Yes, that's a fair statement. I think, yeah, I think nuclear medicine or PRRT is in such an evolving space at the moment. When you look at international data, a lot of departments or previous evidence have basically stuck to a very standardized type regimen. So typically, 4 cycles of PRRT with lutetium dotatate at a certain fixed amount that's injected into the body. And that's fine, because most of the NETA-1 trial, which is the prospective PRRT trial, uses this kind of standardized regimen. But we know, from experience that everyone's different in terms of where the tumors are, how big the tumors are, how much tumors there are in the body. And the tumors may also respond very differently to radiation as well. And with the current benefit of having these very nice PET scans, we do have the ability to be a little bit more flexible in terms of what we use. So if we do identify people with bigger tumors, and we do have, when we had yttrium available, we could sort of tailor the appropriate radiation type to the individual. And at Peter Mac as well, we typically would give 4 cycles of treatment like other centers do, but we can also potentially truncate them to 3 cycles, or give 1 extra cycle as well if there's a need for it.
Grace, there's a couple of questions around PRRT that came through in the questions leading up to today's talk, and one of them I think might be hopefully fairly simple to answer, which was, is PRRT only for liver tumours? So I guess it's, is it effective for tumours elsewhere in the body? And the other question which was linked is talking about liver-directed PRRT. So I'm wondering if we could kill 2 birds with 1 stone and address both of those questions, if that's not too cheeky.
Yeah, sure. So the first question relates to liver. So no, certainly as long as your net tumor cells have the lock, it doesn't matter where they are, the medicine will go to it. So it is not really just confined to the liver that we are treating. It could be, different areas in the chest, in the lymph nodes, in the bones, as long as they are able to concentrate the radiation. And the GATATE scan can tell us that. And the second question is about liver-directed PRRT, isn't it? Yeah. So usually the conventional way of delivering the PRRT is by putting a cannula into your vein in the arm, and by doing that, basically we are giving the injection that goes around your body systemically in a very sort of general fashion, and it will just find and go to the locks, and radiation will stick to it. For some patients who have predominantly disease in the liver, we can potentially deliver the PRRT in a slightly different way. So instead of giving it through the vein in the arm, we can actually look into delivering it via a vessel from your groin, because then the radiologists, who are the people who will be doing this procedure, can actually feed a catheter and deliver radiation from the groin vessels that goes more directly into the liver first, before it then goes around to your body. So the theory is that the PRRT can be attracted and be delivered to the liver tumor, and there will be a much higher load of PRRT going to those tumor first before going around the other parts. So that's the rationale behind it. However, it is a technically sort of tricky procedure to do because firstly, you need to have the right vessel going into the right area of the liver. So special scans, a CT scan will have to be done beforehand just to make sure that your anatomy is suitable for this particular delivery method. And the radiologist will have to put a cannula into your vessel in your groin, which is slightly invasive. And which may sometimes lead to very low risk, but local complications like pain or bleeding and things like that can happen. So it is only really sort of done for very selected people with predominantly liver heavy disease.
And Grace, I'm thinking that I remember back to one of the ENETS conferences I went to when they were talking about clinical trials for that therapy. Are they still, is that still considered like an experimental or trial treatment, or is that being sort of adopted into mainstream a little bit more?
The trial is still ongoing at the moment. An international trial is going. So it will be very interesting to actually have the results of that to see whether directly delivering PRRT into the liver really has any particular benefit over the conventional way, which is into the vein in the arm.
Fantastic. So we just have a few more minutes left. So and Grace has been very generous in the time that she's offering us today, but I'm going to try and whiz through a few more questions if I can before we need to finish up. Grace, actually someone has just written a comment in the feed that they've had one dose of PRRT and so the vast majority of their pain is already gone, which is I think we'd all agree that's a fantastic result. And I guess the question was, can it work that fast? But I also know that there were some questions around side effects of PRRT. So I wondered if we could talk about some of the benefits in terms of what symptoms might be alleviated in what sort of time frames, but also what we're looking out for in terms of side effects.
Yeah. Yeah, the first question is slightly difficult or tricky to answer because I guess the time frame in which we expect symptoms to go away really depends on the individual and what sort of symptoms we're dealing with. In fact, with hormone or functional symptoms that we were talking about before, with the flushing and diarrhea, it may take some time for those to improve. And in fact, in the earlier stages, those symptoms might actually get a little bit worse. The reason being, when we give the PRRT, when the radiation goes into the tumors, it can actually cause some initial swelling. So I usually tell people, like, if I try to give you a punch, Kate, your arm might bruise really badly and it will swell before it gets better. So similar phenomenon with the tumors. When the radiation gets to the tumors, it can make it swell a little bit. And if it's full of hormones, stored within it, it may actually make the hormones come out. And so a couple of days or even up to a week or two after the PRRT, and it's usually after the first cycle when you haven't seen the radiation before, if you have a lot of hormones stored into the tumors, it can make the flushing and diarrhea get worse before it becomes better. But paradoxically, I know it's probably not not good for patients, but we see that as a possible plus, because then we're hoping that the radiation had stirred up something. In terms of pain, again, if the pain is coming from the bones, because bone is such a hard structure, if you get swelling, even within a small lesion in the bone, it can actually cause some discomfort. But once you get through that, pain can actually, be relieved fairly quickly as well. So I think the when we expect it to happen really depends on the different individuals. In terms of other side effects, now that we're talking about it, apart from the tumor swelling, it can cause some discomfort in the local area. Hormone flare that we've talked about before. Usually people actually tolerate the treatment in the department fairly well without immediate problems. The amino acids that we give to protect the kidneys can sometimes cause them nausea or sickness, but we typically would give some steroids or anti-nausea to counteract that, and I think we've got the balance right now. Usually people don't really have any symptoms during the infusion. But in the subacute phase, people need to have their blood test monitored at 2 weeks and 4 weeks after every cycle of treatment, because there is a small possibility that the blood counts may drop, just like any other, oncologic, treatments. But I guess in the longer term, with PRRT, we have seen, some association with blood problems or kidney problems. Kidney problems we're not so worried about if your kidneys are 100% to start off with, but if your kidneys are not so good to start off with, then we would need to monitor that. We find that the majority of patients actually 95% do not have any bone marrow problems, but up to 1 to 5% of people may be associated with another blood disorder, which may be difficult to treat. So these are very important things that we talk to people about before they start the treatment, obviously, to let them know the potential side effects. But usually people tolerate the treatment without problems.
Thank you, Grace. I had one question. It wasn't an audience question. It's actually my question, and I'm looking at my clock and not sure if we'll have time. So feel free to let me know if you just think there is not enough time before you need to run away, Grace.
No, I have time. I have time.
Oh, that's so kind of you. I know everybody who has PRT has an echocardiogram to check the function of their heart, and we've talked in our Facebook Friday videos about carcinoid heart disease and the impact of the hormones on connective tissue. So we already, I think our group are fairly familiar with that as a concept. But what is it about PRRT that we need to be particularly careful about hearts regarding?
Well, that's a good question and a complex question as well. So you mentioned that people are fairly familiar with carcinoid heart disease already, isn't it?
And I'll put a link to that video in the notes, so people can go back and have a look at that. So I think, yeah, right, people are hopefully fairly familiar with the impact on the heart valves.
Okay. Yeah, because as you know, carcinoid heart disease really relates to the heart valves being affected. So, your heart is like a big muscle that pumps blood that flows in one direction from the right side of the heart to the left side of the heart. And basically, just to recap, there are 4 major valves in the heart, which are like little gates, and they coordinate, they flip around in a very coordinated manner to allow blood to flow one direction. But basically, with carcinoid heart disease, and as your audience may know already, one of the valve in particular in the right side of the heart can be affected because the hormones can cause fibrosis and make the heart valve leak. And the degree of carcinoid heart disease or the leakiness of that valve can vary between different people. So it can vary from just a very mild leak where people don't really have any symptoms. It can be picked up on echocardiogram and need to monitor it, to a very severe leak of the heart valve. And in the context of the heart valve being severely affected, what happens basically is there's no longer a coordinated sort of movement, and so blood cannot flow smoothly one direction. And what happens is a lot of blood will tend to go backwards, and it can congest the liver, and it can also cause swelling of your ankles and your legs, for example. When it gets to that point when the heart is severely affected, the only treatment for that really is a mechanical problem. So surgery is the only way to fix a heart valve. So in this context, I guess, just to make 3 points in relation to PRRT. With PRRT, it's unable to fix the heart valve. So we can target the net tumors that are producing the hormones that had led to the development of the heart valves. But once the valve is significantly very leaky, we cannot fix that. The second point is that, with very mild carcinoid heart disease or mild leakage of the valve, is not a problem for PRRT. So we can still proceed on to using our treatment to target the net tumors. But the only concern is when the heart valve is very severely affected. Because when the heart valve is very severely affected, when you have fluid building up in the body, for example, that actually should be a priority to consider treatment for, because then people tend to run into trouble from the heart and from putting strain onto the heart rather than from the neuroendocrine tumor. This is a very generalized statement, but usually when the heart valve is very, very severely affected, that has to be kind of prioritized in the context of when we talk about the treatment. And the third main reason is that when heart valve is severely affected with lots of hormones in the body, PRRT can actually sometimes make people worse. And that is because when the radiation gets into the tumor cells, as we were talking about before, it can cause a flare of those hormones. And usually, you know, people with heart valve problems also have concurrent flushing and diarrhea because of the hormone secretion. And if there's a significant flare of the hormone after the radiation, usually liver can compensate that. But in the context of very congested liver from the heart valve problem, the liver is very difficult for it to process all these extra hormones in the body. So there is a risk of getting into what we call a carcinoid crisis after PRRT treatment, because the hormones just, you know, get elevated and it can't be processed properly from your body. And so people can get worse because it can cause, you know, lots of flushing, diarrhea, and make blood pressure difficult to control. And if the heart is already under a lot of strain, it can cause a lot of problems. So it is a complicated issue. I probably have sort of oversimplified a little bit, but you know, with people with severe carcinoid heart disease and NET tumors that we need to treat, they're often quite challenging, and we would definitely need a multidisciplinary approach in those contexts where we would, you know, bring the medical oncologist in, we bring the endocrinologist in, and speak to the cardiothoracic surgeon to weigh up, you know, how to proceed and the sequence of events. I mean, do we, you know, try to treat the NET first, or do we try to fix the heart valve first? So there's no one general rule, but basically, I think a multidisciplinary discussion is mandatory in these cases. And also, I must say that you know, for any surgeries to happen, it will be good to involve an experienced cardiothoracic team with the appropriate anesthetic support as well.
Oh, thank you, Grace. I know that was a really complicated question.
I hope that was answered.
I know, and that really helped me understand it. So that if it helps me, then it's probably helped our viewers as well. Grace, I know that you need to run away to another meeting. Just before you go, I wondered if I could be really cheeky and just ask you one more question, which is, sure. What's your favorite thing about working in this field? You know, what gets you up in the morning and makes you feel excited about a day at work?
Wow, that's a very interesting question. I was expecting some PRRT related or side effect related questions. Look, I really enjoy what I do. I think in nuclear medicine in particular is an evolving field, and you can see, you know, from the pictures I showed you before that you know, new developments are always you know, coming up. We are using nuclear medicine radiation to look at things, to find things. Once we see them, we can actually potentially use higher radiation to treat them as well. And it's not just neuroendocrine tumor, but nuclear medicine is becoming, you know, quite important in many other types of sort of cancer type monitoring as well as treatments. But, you know, in the context of NETs, you know, we have a effective therapy like PRRT that we can deliver that works for many people, not all, but, you know, we have to select, you know, people properly to have the treatment. So, that's good. But I also enjoy the ability to have a multidisciplinary kind of interaction with other specialties. So we, you know, work really closely with medical oncologists, for example, surgeons, pathologists. We work really well as a team. But I guess most importantly, I love having the interaction with patients as well. And you know, often patients, you know, come back for, you know, their repeat treatment cycles, and they come back for scans and, you know, for ongoing follow-ups. So I think being able to be involved in that process and also getting to know some of the people as well is a very rewarding experience.
Oh, look, that's a beautiful note to finish on, and thank you so much once again, Grace, for your generosity today. I hope that's been helpful for everybody, and it may be that there are follow-up questions that come from this discussion that I might be able to help address in coming weeks. But today we've just appreciated you so much, and thank you to you, Grace. And look, I hope your rest of your day goes well. I'll let you. I know that you've got to run, so I'll let you press the red button to leave the meeting while I do a little bit of housekeeping with the group. But fantastic of you to join us today.
Well, thank you very much for the opportunity to join your meeting, and well done on all the sessions that you've performed so far.
We're on a constant learning journey, aren't we, everybody? I know that we've had our fair share of glitches, but we're getting there.
Thank you very much.
Fantastic. So while Grace leaves us, I just did have a tiny bit of housekeeping for you, and that's just to do a massive plug, because next Tuesday, the 10th of November, is World Net Cancer Day. And that's a big day of focus for us with neuroendocrine tumours in Australia and worldwide. One of the fantastic things that's going to be happening in WA is that there's a petition being handed to Parliament. They've got over 2,000 signatures to hand to Parliament to progress forward the concept of a centre of excellence in WA, which is a really exciting project. There's going to be events or the focus in terms of social media and things throughout the day. So keep an eye on our Facebook feed and Twitter and whatever else is your fancy. But the other thing that I think is really important for you to know is that in the evening, we've got the State of the Nation webinar. I nearly had a little bit of a mental blank there, but we're whirling our way around the country with the magic of the internet and beaming into the main treatment centres in Perth, in South Australia, Peter Mac in Melbourne, and Grace is actually coming back for a repeat performance on Tuesday, where she's going to be talking about some of the really exciting, interesting research that's happening in Peter Mac. We're going up to Royal North Shore in Sydney, and then up to the Royal Brisbane and Women's in Queensland. So we're really excited to have a fantastic panel of speakers who will be all giving us updates on their programs and their research. So we're really looking forward to that. I'll make sure that there's a link for registration on our website for that. The other thing I just did want to put in the diary is on the 23rd of November, Tuesday the 23rd of November. It's a few weeks away, but our NET specialist dietitian from here in Melbourne, Erin Lang, has just finished her PhD into nutritional deficiencies and neuroendocrine tumours, and she's going to be doing a webinar with us on the Tuesday, and then following up a week and a half later for a Facebook Friday special. So we don't have the registration for that webinar yet, but I'll let you know, and I'll post in the group spaces when we've got that ready, and I'll keep you posted about when that's available. But I'm really looking forward to seeing many of you at our webinar on Tuesday night, which is the State of the Nation. So look, thank you everybody. I know that you've hung in with us for a really long session today, but I think it was really worthwhile. Grace said that she would be available for a little bit longer, and I thought, given the number of questions that you all posted, I felt like it would be worthwhile, you know, borrowing a little bit more of your time today to think about those questions and answers. So thank you everybody for sticking with us. I'm going to finish up now. I hope you have a great weekend, and look, I'm in the office this afternoon, so if we need to talk, then I think you know how to find me. Take care everybody.